The child has no history of change in the voice or noisy breathing present, no history of diarrhea, no history of choking spells or convulsions which was related to an aspiration pneumonitis. On past history, the child had a history of cough, fever, breathlessness with lethargy and decreased oral intake, with loose stools and signs of dehydration present at the age of 1 year during the month of May, for which child was admitted in private hospital and was evaluated, and the child was diagnosed to have a chronic suppurative lung disease at 1 year of age and started on treatment. On probing to the other histories, the child had a recurrent respiratory tract infections, for which the child was being admitted in the past 2021 for 4 times. At the month of January, child was admitted with a cough with expectoration, breathlessness and fever and treated with IV antibiotics for about 7 days. During the month of March, child was admitted for the similar complaints for about 2 weeks and was treated with IV antibiotics and on the oxygen support. During the month of July, the child was being admitted for 3 weeks, treated with IV antibiotics and an oxygen support initially. The child was present admission was on 26 December. In between the episode, the child has intermittent cough, was not associated with a breathlessness and fever. There was no history of any exanthematous fever in the past. Antenatal history, mother was registered and an immunized pregnancy. There is no history suggestive of gestational diabetes mellitus or pregnancy-induced hypertension and hypothyroidism. No history of fever with rash or lymphadenopathy. No history of any drug intake or radiation exposure in the mother. I'm going to the natal history. The child was a late preterm, born through LSCS. Birth weight was 2.5 kgs, cried immediately after the birth. There's no history suggestive of respiratory distress at birth and there was no NICU admission. I'm going to the postnatal history. The child was breastfed within 1 hour of the birth, passed urine and meconium within 24 hours of life. No history of prolonged jaundice. Development history, the child was developmentally normal child studying in the class 1. A nutritional history, the child had a calorie intake of 900 kilocalories for expected of 1500, a deficit of about 600. Proteins was about 22 grams with expected of 40 grams and deficit of around 18 grams. On going through the family history, child was a firstborn child of a non-consanguineous marriage. There was no any history of abortion or stillbirth, no family history of any infertility among the relatives, no history of similar illness among the family members. Socioeconomic history, they lived in a paka house with the 2 rooms with the 2 windows each. They have separate sanitary facilities. Water is from the municipality. Father's education was about high school. Occupation was a semi-skilled laborer with a monthly income of 15,000 per month. So according to the modified Kupusami scale, they belong to a class 3 lower middle class family. On environmental history, there is no history of passive smoking, no history of exposure to the pet animals. They use the gas stove for cooking. Immunization history, child was immunized according to the national immunization schedule and was also given additional vaccinations like pneumococcal conjugate vaccine on the 7th March of 2021, followed by a polysaccharide vaccine 8 weeks later. The child was also given an influenza vaccine annually. Allergic history, child was not allergic to any type of food or drug. On contact history, there is no history of contact with an active pulmonary tuberculosis patient in the past. Treatment history, child was on the vitamin supplementation and the drug prescribed by the physician for the past 4 years. Going on to the summary, a 6-year-old female child, firstborn of non-consanguineous marriage, who had recurrent respiratory tract infection with a passage of bulky and oily stools with an inadequate weight gain, diagnosed as a chronic suppurative lung disease in the past, presented with a worsening of respiratory symptoms, probably an exacerbation this time, sir.
Can we go back to the first slide?
Yes, ma'am. Yes, ma'am.
Your first slide. Generally, don't tell the name of the child because it's going to be on the net and everything. So for confidential issues, you can name the child as child Y or something. So don't bring the name of the child in your presentations.
Okay.
Next slide. Next slide now. How do you know the sputum was copious?
Ma'am, mother told it was a handful of sputum, ma'am.
So you want
The
to
child
quantify
had,
it?
while during quantifies when more than 100 ml is a copious amount of sputum or it's a bronchoria, ma'am. That's
Okay,
in
does
for
the child
adults.
bring out 100 ml of sputum per day?
No, normally it is 10 ml per day, ma'am.
This child I'm asking, how did you come to the conclusion that it was a copious amount of sputum?
He asked that mother explained it was a handful of sputum in the early morning hours, so we termed it as copious in that nature.
So at least it should be handful, or if they're using this, they are carrying a sputum cup or a container for spitting of the sputums, then it probably the sputum is copious. Children don't usually bring out 100 ml of sputum. That is the usual definition for copious sputum in adults. And what do you think if it is foul smelling? What is information does it give you?
It is organisms, by anaerobic organisms mostly have a foul smelling sputum.
And why do they have awakening, or why does it exacerbate during the early morning hours?
Because of the postural variation during the sleep, the sputum gets collected in the bronchus and it gets they are coughed up in the early morning.
So in this child, you were talking about exertional dyspnea, no? There was a grading of dyspnea.
Yes, ma'am.
Child had grade 1 dyspnea and then progressed to grade 4 at present.
Yes, ma'am.
So what information does it give you? What system is involved if you have exertional dyspnea?
Exertional dyspnea mostly cardiovascular system, ma'am.
Yes, always. External dyspnea tells you what cardiovascular dysfunction.
The aortic stenosis or congenital aortic stenosis will have an exertional dyspnea, ma'am.
Okay, but generally, what does external dyspnea tell you? It tells you about ventricular dysfunction. So when you have exertional dyspnea, which goes from grade 1 to grade 4, it means left ventricular dysfunction. Can exertional dyspnea occur in respiratory system?
Yes, ma'am.
In what case? So if you have pneumonia, child will be dyspneic at rest. If you have a bronchitis, which is involving both the lobes, child will be dyspneic at rest. And if the child is going to exercise, then the child will again have increasing dyspnea. So that doesn't mean exertional dyspnea. The child will be breathless at rest in all if there is dyspnea, if the involvement of the lung is severe enough. So they will not have a progression of dyspnea from grade 1 to grade 4 in pulmonary causes of dyspnea. Okay. Even in bronchitis, if the lung is involved to a sufficient extent to cause dyspnea, the child will be dyspneic at rest. Usually, grading of dyspnea or exertional dyspnea occurs only in LV dysfunction, or if it is a chronic case, what respiratory cause can cause exertional dyspnea. In a chronic case, this child has been symptomatic since 2 years of age.
Yes, ma'am.
2 years of age. So what can cause, what could be the current problem that can cause exertional dyspnea?
Viral infections, post-viral infection can cause an exertional dyspnea in this child.
That is what I'm trying to tell you. When there is an exacerbation of viral infection, child will be dyspneic at rest. It will not have a progression or grading of dyspnea unless the child has pulmonary hypertension. So chronic disease like a severe lung disorder, which has been present for more than 5 years, can cause exertional dyspnea. Otherwise, all pulmonary cases or respiratory involvement, they'll be dyspneic at rest. Now, ILD will be dyspneic at rest. And if they're going to play, there'll be increasing of dyspnea. Okay. So at rest, they'll be dyspneic. So usually we don't grade or we don't have exertional dyspnea in pulmonary causes. Okay. What is the fever? It is a low-grade fever.
It's a low-grade intermittent fever, ma'am.
Okay. Next slide. Dr. PSC has asked, how did you diagnose sinusitis, or what history you asked for sinusitis?
Headache or facial swelling or a
The age of this
postural.
child?
6 years, ma'am.
So with sinusitis, will you get headache?
No, in children we mostly don't get headache, ma'am.
In which sinus involvement we get headache?
Frontal.
It's the frontal sinus. So when does the frontal sinus come up?
At 7 years.
It starts appearing by 7 years, and when it is completely pneumatized?
Adolescence.
Okay, it takes adolescence or adults. So headache is usually not a symptom of sinusitis in children. But can children get sinusitis? A 1 year old or 2 year old?
Yes,
Yes,
ma'am.
So which sinus is present at 1 year old?
Ethmoidal sinus.
So the ethmoid is pneumatized and present at 1 year old. So what history you ask for sinusitis in this child?
Nasal discharge,
Purulent nasal discharge.
purulent nasal discharge, facial edema, and cough with persisting more than 14 days, or severe nasal discharge with fever for 3 to 4 days, or history of double sickening.
Okay, very good. So that will be your usual. You don't ask for headache or all that in this age group. So a persistent nasal discharge which is not reducing by more than 2 weeks, or there is a double sickening or severe symptoms, think about sinusitis. But there's no history of sinusitis in this child.
No, ma'am.
Okay. What was the oil and bulky stools? What was the frequency of oil and bulky stools?
Since at that time, at the age of 1 year, the child had an oily and bulky stools, which was 4 times per day, ma'am. And then they started on the medications, and the frequency was reduced, ma'am.
How did you get the history that it was oily?
Which was floating in the water, or which is sticky through the basin, ma'am.
It will be difficult to wash out.
And
So that
also
will be
foul smelling.
foul smelling. So that should be coming in your history. The frequency also should be mentioned. How many days per day the child passes bulky stools in a day? Dr. Terence, do you want to add?
Yeah, I think you have asked all the pertinent questions, and only thing is, as you said, like I think we have to maintain confidentiality in a Zoom meeting like this. I think we should not mention the name. First, second thing is the presentation is good. You have taken lots of history, but do you think it's acute process or a chronic process?
Chronic process, sir.
Chronic process. But your history of present illness include only the 2 weeks of illness, and everything, like went into the past history. Do you think it's the same process or a different process?
The
Same
process
disease or a
with
different disease?
exacerbation of this.
Yeah,
Exacerbation
therefore,
of chronic process.
if it is the same disease, probably flare-up of the same disease. Therefore, you have to bring in from the, I think, infancy. The history should come in from the infancy, when it initially started and how it progressed. Therefore, we have put all those things in the past history. Past history is for a different illness. If it is a different illness, we can put in the past history. It's the same illness. Therefore, everything should come in the history of present illness. Probably your chief complaints might tell that this child presented with 2 weeks of, cough with expectoration. But your history of present illness should start from infancy when the actual process starts. And I'm not sure, if most of my patients don't expectorate till they're quite old, and your history, this child is quite, good. Probably the physiotherapist has, trained the child. The child is coughing out a lot, but that's probably another thing. And sometimes what happens is, don't need to put all the negative, histories, like pertinent. There is no history of constipation. Why there is constipation here? I'm not sure.
Risk of distal ileal intestinal obstruction in cystic fibrosis. It will cause chronic constipation.
That presents with acute cough.
Also.
So when you suspect,
Oil stools and inadequate weight gain.
That's an acute process. This DIO is an acute process. You don't present with chronic constipation. It's an acute process. It presents like appendicitis. Therefore, I think if you put lots of negative history, and if you're not able to explain, then you will get into problems. I think whichever you are very clear, then you are able to explain nicely in sinusitis, and no history of chronic nasal discharge. What does that mean actually?
The nasal discharge for more than 4 weeks is defined as chronic nasal discharge, sir. It is mostly pertinent to any ciliary impairment in a child, sir.
is it different from sinusitis?
Is it different from how it is different from sinusitis?
In this, the child will have only the nasal discharge and not any other symptoms associated with sinusitis, like facial edema or.
Usually, like if it is a primary ciliary dyskinesia, the nasal discharge usually starts from the neonatal period or early on the first 6 months of life. Therefore, if a chronic nasal discharge is there for like past 1 month, that doesn't mean it's it's a primary ciliary dyskinesia. Therefore, early onset, persistent nasal discharge, which is not episodic, it's persistent. Episodic is usually an allergic problem. Okay, therefore, got a good history, and it will be better if I presented everything in the past history, in the history of present illness, telling that this is a chronic respiratory problem. Probably, as from whatever we have heard, that this child is bringing out copious sputum. We are thinking in terms of airway disease. Okay, airway disease or chronic suppurative disease, and that has involved that has some extra pulmonary features which I have mentioned. That's quite suspicious, bulky stools, and which has had an impact on the growth of the child as well. That's what I have mentioned so far. Ma'am, if you're okay, we can go on to the rest of the things. Family history. Yeah, we'll go to the family history slide. Family history.
Why did you ask for no change in voice?
Ma'am, when there is a palatal dysfunction or vocal cord dysfunction, there can be an history of an aspiration, which can lead on to this chronic wet cough. So I ask for that change in voice. Or when there is a
dysfunction.
Or when there is a gas.
Go on. Go on. What did you say?
There's a palatal dysfunction, or there will be a chronic aspiration which can lead on to this chronic wet cause for this chronic wet cough.
So palatal dysfunction will cause change in voice, huh?
Hypernasality of voice will be present.
Okay. So suppose there had been a pseudobulbar or bulbar palsy, then there'll be a hyponasality of voice that can cause recurrent. That may be a cause of recurrent aspirations and bronchiectasis-like symptoms. Okay.
Family history.
Doctor, next slide, please. Doctor, next slide. Yeah. Why this history is very important? Socio. Yeah, you go to the previous slide.
Yes, Socioeconomic history.
Why this history is very, very important. I will be very interested in this history for this particular child.
Sir, in this child, we are suspecting chronic suppurative lung disease, probably due to cystic fibrosis. The prognosis of this child depends mainly on nutritional status and socioeconomic status.
It's important you have taken history, of any environmental factors that can, that can be, have a negative impact on the disease, like as you asked, smoking is very, very important. Exposure to any other, smoke, household smoke. And other thing is not only for cystic fibrosis, any chronic respiratory disease, for say any chronic disease, you have to take the biopsychosocial model, because the parents have to support this child. Their education level has to be good, and they should be able to support the child financially as well to get the medicines. Therefore, when you plan treatment based on their counseling. Everything depends on their understanding, and you have to give lots of training. Therefore, everything depends how educated they are, or how involved they are. Sometimes if parents are involved, those children do quite well. And other thing is as you said, income is also another important factor. Therefore, you have got all the pertinent questions. Yeah.
Have you mentioned about cyanosis? Was there cyanosis in the child?
No,
History of cyanosis? You have mentioned that?
No, ma'am.
Not mentioned. Usually, you have to mention whether there was bluish discoloration, or even history of clubbing can be asked in the history. So what disease will cause cyanosis along with chronic dyspnea?
interstitial
Respiratory
lung
first. Yeah, okay. Any long-term history, ILD will be an important differential diagnosis. Of course, they will not have this type of copious sputum. But any chronic history, ask for history of cyanosis. You can also ask for history of clubbing also in your history itself. So that will give you an idea of whether it is ILD or bronchiectasis. And second is, it gives you an idea about the chronicity of clubbing. I mean, the chronicity of the disorder also, if there is clubbing in your history. Okay. So every time the child was hospitalized, was the child nebulized or something?
Yes, ma'am. Child was nebulized with hypertonic saline, ma'am.
So this all these 3 admissions, was fever an important symptom?
Yes, ma'am.
Fever was an important symptom in all the 3 admissions. Huh?
Yes, ma'am. It is important. Because of an acute exacerbation, the cystic fibrosis exacerbation, fever will be an additional point for the exacerbation.
In cystic fibrosis exacerbation, fever is not usually a symptom because it is a localized disorder. That is, all the processes are localized to the lung. So fever will be the last symptom in an exacerbation. So just wanted to know whether there was every time there was pneumonia or every time the child had a wheeze and was hospitalized and given nebulizations.
Child had cough with expectoration, breathlessness, and some changes were present in the X-ray, ma'am, compared to the previous one.
So child was treated with IV antibiotics.
IV antibiotics, ma'am.
Okay. Okay. Shall we move on, sir?
Yeah, we'll move on to the summary slide, ma'am. Summary slide.
So do you want to say it's recurrent respiratory tract infections, upper or lower?
Lower respiratory tract infection, ma'am.
So how did you derive that?
Because it's cough with breathlessness and also the expectoration was present. Plus, the child had a radiological feature of during the each admissions, ma'am.
That you didn't bring the history, but needn't be brought in the history also. Okay. So what chronic suppurative lung disorder are you thinking?
Mostly bronchiectasis, ma'am.
So thinking of bronchiectasis.
Yes, ma'am.
Bronchitis, is it a clinical diagnosis or radiological diagnosis?
Radiological diagnosis, sir.
Therefore, if you mention chronic suppurative lung disease itself, it's enough. No, like, yeah. Ma'am, shall we move on to the exam?
We'll go on. Yeah.
Moving on to the general examination, child was conscious, oriented, afebrile. She was asthenic and dyspneic at rest. Pallor was present. Child had a grade 3 pandigital clubbing was present. There was no cyanosis, not ectric. There was no generalized lymphadenopathy. No bilateral pitting pedal edema was present. There was no external markers of tuberculosis.
What external markers of tuberculosis should you look for? In
eyes, we look for the flictin, ma'am, for scrophulodderma, erythema nodosum, lymphadenopathy, lymph nodes, ma'am.
Tuberculosis. What is the external marker of tuberculosis? All these are hypersensitive reactions, lectins, even lymph nodes, scrophulodderma, and all that. The external skin marker of tuberculosis is?
Lupus vulgaris.
Lupus vulgaris. Okay. Okay, go on. Go on, doctor.
Anthropometry, the child's weight was 9 kgs, height was 99 centimeter with BMI of 9.18. According to the IFB percentile growth chart, weight for height was less than 3rd percentile, height for age was less than 3rd percentile, and BMI was less than 3rd percentile. Going on to the vital signs, the pulse rate was 140 per minute, it was regular in rhythm, normal volume in character, felt equally in all peripheral vessels. And the respiratory rate was 46 per minute, a thoracic type of respiration. BP was 90/60 in the right upper limb with the patient in a sitting posture. Temperature was 98.9 degree Fahrenheit with the saturation of 96% with O2 and 90% in the room without O2. On going to the head to foot examination, head was normal. In eyes, there was no bite or spot, no conjunctival dryness, and no flictin. Ears normal, there was no discharge. Mouth, there was no cheilitis. Neck was normal. Extremities were normal with the BCG scar present. Chest wall, there was no deformity. Abdomen normal. The skin, no erythema nodosum. External genitalia normal with the standard staging of stage 1 was present. Spine, there was no kyphosis, scoliosis, or no gibbous or no spinal tenderness were present in this child. Going to the upper respiratory tract examination, nasal cavity, nasal flaring was present, no deviated nasal septum, no polyp or no sinus tenderness. Ear, external auditory canal, bilaterally it was normal, there was no discharge. Tympanic membrane was pearly white on both the sides. Oral cavity, there was a good oral hygiene, no dental caries, no cleft palate, no oral thrush. Tonsil was present within the tonsillar fossa. Halitosis could not be made because of wearing the mask. Going on to the lower respiratory tract examination, on inspection, trachea appears to be in midline, apical impulse visible at left fifth intercostal space, 1 cm medial to the mid-clavicular line. Chest wall was symmetrical. Movement of the chest wall was symmetrical, which was equally with respiration. Intercostal retraction was present, subcostal retraction, suprasternal retraction was present. There was a supraclavicular hollowness was also present. There were no drooping of shoulders. Skin over the chest, there was no sinus, scars, or engorged veins. There were no bony abnormalities. On palpation, tracheal position confirmed to be in midline. Apical impulse confirmed to be in left fifth intercostal space, 1 cm medial to the mid-clavicular line. Chest expansion was 3 cm. During inspiration, it was 55 cm, and in expiration, it was 52 cm. Movement of the chest wall was equal in all areas. Anteroposterior diameter was 13 with a transverse diameter of 17.5. There were no chest wall tenderness or no tactile firmitus. On percussion, there was a increase. Vocal firmitus, it was increased over the inframammary, infrascapular and interscapular and infrascapular area in the right side, ma'am. On percussion, direct percussion, it was resonant. On indirect percussion, dull note was present in the inframammary, infraaxillary, infrascapular and interscapular area. Tidal percussion was resonant and top space was resonant.
Okay, can we go back?
I see. On auscultation, the child had a normal vesicular breath sounds heard over all the areas except in the right inframammary, infraaxillary, infrascapular area where there was a bronchial breath sounds heard. Child has had a persistent bilateral coarse leathery crepitations over the lower zones of both the chest wall, and child had a vocal resonance were increased in the right side inframammary, infrascapular, infraaxillary regions on the right side, ma'am.
It was what? It was increased. Vocal
Yes,
resonance was
increased.
It was increased.
Yes, ma'am. Another system examination, first and second heart sound were heard normally. No single loud second heart sound heard in the pulmonary area. No murmur. Mild abdominal distension was present. There was no organomegaly. Bowel sounds were heard normally. Only to the central nervous system, higher mental function were normal, and there were no neurological deficit. No. Diagnosis: a 6-year-old female child with a history suggestive of chronic suppurative lung disease, presented with an exacerbation. Examination findings suggestive of coarse crepitation, which was present bilaterally in the lower zones. It was a bilateral bronchiectasis with a right middle and lower lobe consolidation with severe thinness without any features of pulmonary hypertension. The probable etiology was towards the cystic fibrosis, which was an exacerbation.
Okay, go back. Go back to your first slides. So these areas, in children, we have supraclavicular, infraclavicular, and mammary areas. There is no inframammary, as Dr. PRC sir has pointed out. Similarly, they have interscapular, suprascapular, and infrascapular. Then you can comment upon the axillary and infraaxillary regions. There is no inframammary region in general examination, in examination of the RS in children. Okay. And what is the build of the child? The child appears asthenic, dyspneic at rest.
Ill-built, ma'am.
It is still built. Pallor, what is the degree of pallor? It is some pallor or a severe pallor?
It was some pallor only, ma'am. The crease was present. It was only some.
Dark. Okay. So it's grade 3 pan digital clubbing. So the lower limbs also had clubbing. Huh?
Yes, ma'am.
Okay. Okay, go on. Next slide.
Anthropometry, ma'am.
Okay, next slide.
Vitals, ma'am.
You didn't mention about the type of breath sounds.
Ma'am, the child had normal vesicular breath sound heard all except in the right mammary, infraaxillary, and the infrascapular area. Child had a bronchial breath sounds, ma'am.
Child had bronchial breath sounds.
Yes, ma'am.
In those areas.
Yes, ma'am.
Okay. Dr. Terence?
I think you asked, I think, all the important relevant questions. And go to the diagnosis part. Like,
How did you say it was coarse crepitations?
It was a leathery crepitations, which was a low pitched sound, ma'am. Whether it were fine crepitations would be a high pitched and a Velcro type sound, ma'am.
So coarse crepitation, what phase of respiration are they present?
It is present in both inspiratory and expiratory, ma'am.
Okay, so it is present in both phases of respiration, and at least it starts from the late inspiratory and throughout expiration. It is because of the air moving through the secretions in the airway. So coarse crepitations are it should be present in both phases, and it is loud and it is high pitched. Okay.
Yeah, and the thing is, like Dr. PRC sir has asked some relevant questions. One of the things is you have mentioned in the history of chronic suppurative lung disease. Is it the patients themselves said chronic suppurative lung disease, or, how do you got that history?
Sir, it was diagnosed at 1 year of age, and mother told that the child had some lung disease. It was and it was started on medication from 1 year of age, sir. So since it was from 1 year of age, we thought it to be a chronic thing.
Yeah,
and
I
child
think
also had a cough with an expectoration, so it was related to a suppurative and chronicness.
Yeah, if you are putting that in the history of present illness, or in the in the history of present illness, you have to mention patients, the parents' own words. You can't interpret as chronic suppurative lung, the history of chronic suppurative lung disease given by parents. Okay, and other thing is, like, treatment history was not adequate. What kind of treatment they were getting in between these episodes, that's very, very important. How they are managing and what kind of occupations parents are. And that really helps. Like we didn't have those kind of things.
Semi-skilled
And what
workers.
like,
it was welding workers, sir.
Okay, construction. They're working in the construction industry. Yeah, and what other thing I was asking? Like, yeah, and this is more of as you said, like more of bronchiectasis of lower lobes, and if at all, if it is cystic fibrosis, or which part of the lung will get involved most?
Predominantly upper lobes.
Predominantly upper lobes. Then is a bit contradictory. Therefore, it's very that is a bit contradictory. And the other thing, which in which disease we get middle lobe involvement?
Allergic bronchopulmonary aspergillosis, middle lobe can be involved, sir.
Uncontrolled asthma, atypical mycobacterium.
Usually, like primary ciliary dyskinesia involves middle and lower lobe. Primary ciliary dyskinesia. If it is post-infective, it's usually aspiration. Usually involves the lower lobes. Therefore, those sort of things. And you have not mentioned here in the history anything about malabsorption history. Okay, probable malabsorption is also there, and vitamin deficiency. That doesn't have any vitamin deficiency.
Examination part we have told about there's no white hot spot in the
Therefore, those things are very important in examination. Okay. Therefore, this is more of a chronic suppurative lung disease with history suggestive of some malabsorption going on, and the child is not thriving well, and there is nothing to suggest from examination child has got vitamin or micronutrient deficiencies. Like. And what about the treatment part? What kind of treatment they were getting in between these episodes? You said the child was diagnosed as chronic suppurative lung disease, from 1 year of age. What kind of treatment they were getting?
The child was started on the vitamin supplementations, fat-soluble vitamin supplementations, and child was also given an pancreatic enzyme lipase supplementation was started, sir. And the child was given on antibiotics only when the child had an illness, sir, not on a regular treatment. Child was not put on any prophylaxis, sir.
Okay. This was when the treatment?
Sir?
When was this treatment started? 1 year of age or?
It was pancreatic lipase capsules were started from 1 year of age, sir, and vitamin supplementation was also started from 1 year of age. And mother was taught for chest physiotherapy for that child, sir.
At what age they started chest physiotherapy? At what age?
Sir?
What age they started chest physiotherapy, airway clearance therapy?
That one only when the child had a cough or when they started.
No. For this patient, what age they started chest physiotherapy?
Infancy days. From the 1 year of age, they started chest physiotherapy, sir.
Okay, this all the treatment the child was getting from 1 year of age.
Yes, sir.
Okay.
So they diagnosed bronchitis at 1 year for this child. They started physiotherapy at 1 year.
The diagnosis cystic fibrosis at 1 year, ma'am. Physiotherapy was taught when the child had an exacerbation or when the child had a cough with expectoration. Mother was taught to do a physiotherapy, ma'am.
From 1 year. So the diagnosis of CF was made for this child at 1 year of age.
Yes, ma'am.
Okay.
Sir wants to know, how did you make out nasal flaring with a mask? Yes, sir.
We told the child to remove the mask, ma'am. We were wearing.
But you said you couldn't look for halitosis.
We were wearing masks, so we couldn't take the halitosis.
Okay. Okay, so as Dr. Terence has pointed out, right and middle lobe involvement is a little rare in cystic fibrosis, a little against our usual findings. And vitamin deficiency, we should have mentioned in the final diagnosis also. So history suggestive of chronic suppurative lung disorders. And what is the type of bronchial breathing you observed in this child?
Tubular. It was tubular only, ma'am.
It was a tubular breath sound.
Yes, ma'am.
Okay. Shall we move on, sir?
Yeah, we can proceed, ma'am.
On going to the investigations, complete blood count, total count was 11,300 with neutrophils of 68%, lymphocyte of 24, and mixed was 6.4, HB of 9.8 gram per deciliter with platelet count of 566,000. Liver function test was within normal limits. With the serum albumin was 3.2. It's the normal serum electrolytes. CRP was positive in this child. With the random blood sugar was 108 milligram per deciliter. With the serum calcium was 9 and serum phosphorus was 4.1. MAN2 was negative in this child. The chest X-ray of this child during this admission. It is a sputum of the child. Sputum culture sensitivity showed and Pseudomonas aeruginosa was isolated in the culture. The sputum acid for bacilli was negative. The CBNet was also negative. Sputum fungal culture sensitivity was negative. A bronchoscopy was done. It was a normal, and bronchoalveolar lavage was taken and it was sent for the culture sensitivity. The child, in spite of pancreatic lipase capsule, the child had a fat globules were present. The immunoglobulin profile, which was done earlier, which was normal. Child status was non-reactive with HbA1c of 4.5%. USG abdomen was normal and echo was normal in this child. Now, this is CT imaging of the child. The sweat chloride test, which was done earlier, ma'am. Initial sweat chloride first was done at 58.9. Next was 55.5 milliequivalents per liter. They have also done a mutation analysis study, which showed a pathogenic variant of two mutation causing safety of gene. This was a clinical picture of the child in this world.
So why is the child referred to you? She had a diagnosis of CF. She was started on pancreatic enzymes. She had a diagnosis mutation study. Why was the child referred now?
Child, for exacerbations, child was referred here, and for the financial support, mother couldn't. I mean, they couldn't afford at the private hospital. They required me.
Does the child require bronchoscopy?
Actually, the child, during this admission, child was a little bit sick, ma'am. So we couldn't find other, or for finding like other organisms, it could be an atypical mycobacterium or a fungal culture.
The child had copious amount of sputum. She was bringing out cups of sputum, a handful of sputum. This bronchoscopy is indicated in this children, not in this child. I'm just asking generally in cases of bronchitis. What is the indication of bronchoscopy?
For finding any congenital anomalies or any
So
retained.
when will you think of congenital anomalies?
When the child having a breathlessness or cough, since neonatal period itself.
More than that, when you're looking for focal bronchitis, when your findings are very focal, that is only the left lower lobe is involved, or suppose only the right upper lobe is involved. It's a focal bronchitis. What could be the possible etiologies?
In a retained foreign body,
I was under the
impression we are going
or it could be any lymph node compressing the extraluminal things compressing the bronchus, or any vascular ring.
So something within the bronchus. One is it could be an endobronchial tumor, or as you said, a foreign body, or there is some thing in the bronchial wall, that is bronchial stenosis or atresia, which is causing an obstruction and retention of secretions. So when you have focal bronchitis, then probably you will go bronchoscopy will be your diagnosis of choice. But in a child, in this child who is bringing out cups of sputum or bilateral disorders, bronchoscopy is not it is not actually indicated. If the child is not able to bring out sputum in a child with bilateral disease, then probably bronchoscopy can be used to take out a bronchial lavage, especially when the saturation was only 90% in room air and only 96% with oxygen supplementation. Bronchoscopy generally is not indicated in bilateral disorders. Do you want a CT in this child? Did you want a CT?
It was done 1 year back on this CT. It was not in this admission.
So it was not in this because your findings also not reflecting in the CT. So what is the type of CT that is indicated, and what are the findings that you expect?
It is a.
Can you just show your X-ray? Can you read the X-ray?
It is a AP view of the AP view with the child showing hyperinflation with peribronchial thickening is present with right middle and lower lobe consolidation with the cardiac silhouette is present in the right side, right margin of the heart, ma'am.
So if the cardiac silhouette is present, what lobe of the lung is involved?
Right middle lobe, ma'am.
The cardiac silhouette is present. It is the right lower lobe that is involved if the cardiac silhouette is present. And does the findings look like consolidation? They look like minimal infiltrates. There are some cystic stage changes seen in the right lower zones. But the child had bronchial breath sounds.
Yes, ma'am.
Okay. What are the other findings you will see on an X-ray in bronchitis?
Next, a peribronchial thickening will be there. There will be a loss of lung volume can be present. With the increased prominent bronchovascular markings can be present, ma'am.
So this is the admission X-ray or not?
This is this time admission X-ray, ma'am.
This time admission X-ray, because it is not correlating. This is Dr. PRC's question, but it's not correlating with your findings actually. Okay. Go on. What are the findings in you expect in bronchitis?
In HRCT, ma'am?
In X-ray.
In X-ray, loss of lung volume with the peribronchial thickening and prominent bronchovascular markings will be present, ma'am.
What is
Latest
meant by
prominent
prominent bronchovascular markings?
Increased bronchovascular markings, ma'am.
What does that tell you? Increased bronchovascular markings. Loss of lung volume is one important. When there is a long history, then there can be loss of lung volume, especially if one or two lobes are involved. Probably the left lower lobe, the right lower lobe, there will be loss of lung volume on that side. That is one thing. Then you can have what else?
Crowding bronchus.
Another?
crowding of bronchi.
Crowding, loss of lung volume. How will you find out?
Crowding of ribs.
Either crowding of ribs. So that is how you find out loss of lung volume. Or if it is unilateral, there will be shift of mediastinum to that side along with crowding of ribs. That is how you find out loss of lung volume in one particular lung. Okay. So that is one thing. What are other things that you see on X-ray?
Cystic changes will be there.
So you can see cystic changes. There are some amount of cystic changes which are seen actually in the right lower lobe, even in this X-ray, and also in the left lower lobe. So if there is progressed bronchiectasis, you can make out the cystic changes. Then honeycombing is the end stage. That is, we're not treating properly, and both the lungs are destroyed. It is you will have honeycombing. But before that,
dilated bronchi can be seen.
Dilated bronchus. So what is the shape that is called?
Cylindrical tram track lines.
So sometimes tram tracking can be present. That is a dilated and a bronchus with the thickened bronchial wall. And sir wants to know whether this X-ray is hyperinflated.
Yes, ma'am, hyperinflated.
How many rib spaces can you count?
8 to 9, ma'am.
8 to 9. It is an AP view or it's a PA view? 5, 6 spaces. This is a PA view, and you have only 6 intercostal spaces are present. So more than 6, it's hyperinflation. So it is not a you don't expect a hyperinflated lung in a long-standing cystic fibrosis, isn't it? What is the usual cause of the lung picture in cystic fibrosis? How will be the lung X-ray in cystic fibrosis? If you suppose you're taking it 1 year or 2 years, what will be the lung picture?
Hyperinflation.
Okay. Only in the early stages you'll have hyperinflation. Why hyperinflation at that time?
Can present as recurrent bronchiolitis.
Bronchiolitis. So in that case, initial stages they'll be presenting as bronchiolitis, and then you'll have bronchiolectasis. So in those conditions, you'll have air trapping and you'll have hyperinflation. As the disease progresses, there'll be more of volume loss and under aeration rather than hyperinflation. So in a child with long-standing history, whatever be the etiology, except of course if it is asthma, we don't expect hyperinflation, and definitely this X-ray doesn't require to be hyperinflated. Next slide. Why did you want to do HbA1c in this child?
Ma'am, because child was not gaining any weight, ma'am, but there's no significant history of polyuria. But if you do a HbA1c, the pancreatic involvement in cystic fibrosis, and if you supplement with an insulin, there can be an improvement even in the pulmonary.
So when is the usual age they go in for diabetes?
10
years.
So usually in children more than 8 to 10 years of age. Less than 6 years, they don't usually go for pancreatic insufficiency or endocrine pancreatic insufficiency. So I don't think HbA1c is required. What is the ideal method of requiring fat malabsorption?
Fetal elastase.
You wanted to do fecal elastase. Did you attempt?
No, ma'am, fecal elastase was not done.
So what is normal fecal elastase? Below which you will tell it is
less than 50 micrograms per gram of stool.
Less than 200. Less than 200 per gram of stools is you should think of pancreatic insufficiency. So stool for fat globules is positive, but what is the ideal method of recording fat malabsorption?
Fecal fat content. When for a fecal fat content?
3 days stool should be
3 days, 72 hours stool fat estimation will be the gold standard. But because it is cumbersome, we don't go for it. we go for other parameters, especially clinical or probably stool elastase, fecal elastase. Stool for fat globules again is a little, although we do it routinely, it is not an ideal test. So as sir has commented, blood sugar estimation would be enough in this child. HbA1c, we don't expect adapters in a 6-year-old in this child. Why did you want an ultrasound abdomen and an echo?
Echo for ruling it in a pulmonary, because the child was a chronic long-standing disease to pulmonary hypertension. We have done an echo for this child.
But you didn't have any findings suggestive of pulmonary hypertension. So what are the findings you will see in pulmonary hypertension?
Second sound will be allowed and a single second sound can be heard, or with the ejection systolic murmur with variation in the saturations can be present.
Okay. But you said exertional dyspnea. So if this child had a chronic history and exertional dyspnea, I'd be still looking for evidence of pulmonary hypertension, especially if there is baseline hypoxia. But this child, you said there was no clinical signs of pulmonary hypertension. And why did you want an echo for ultrasound for?
For a follow-up.
What do you want to follow?
Biliary cirrhosis.
I would look for biliary cirrhosis. Why biliary cirrhosis in this child? So it is not warranted, I think. I mean, it's not going to give you any additional information. Okay. Go on. Dr. Terence, you want to add?
I'll go to the first slide investigation. First slide, please. You have put blood counts. So what are the things that will give clues in in cystic fibrosis, in blood counts?
During exacerbation, there can be a neutrophilic predominance can be present, sir. So my lab criteria.
Okay. Therefore, when you diagnose a cystic fibrosis, fresh, what things that will help you is patient will have anemia, because of malabsorption. Most of the times it's hypochromic microcytic anemia. Okay, that's very, very important. And other thing is, even though neutrophils are there, they won't be able to function effectively in a cystic fibrosis lung. Therefore, it has given clues in some patients in a patient presenting like bronchitis, but the counts is quite high, 20,000 with neutrophilic leukocytosis. That has given clues to make a diagnosis of cystic fibrosis in some patients. Therefore, if you have very high counts with polymorphic predominance, that's again subtle evidence that something is chronic suppurative lung disease is going on in the lung. We have seen in some patients that has even given clues. And as we have already mentioned, the LFT you have done is normal. Therefore, in this age group, ultrasound is not specifically warranted unless if the patient has got some signs of liver disease, is not warranted. And I think Rema ma'am has asked serum electrolytes. So what is a usual profile in here in cystic fibrosis?
Hyponatremic, hypochloremic.
Hyponatremic,
Hypochloremic.
Metabolic
alkalosis.
You get a pseudobotted like picture. That's usually in summer when they come with vomiting, tiredness, and dehydration. You expect acidosis, and this is one kind of presentation they usually present with. When you find a child dehydrated and having metabolic alkalosis, this is one of the important DDs, and they come fresh. And even patients who are already diagnosed, they can present like this. Therefore, what important treatment will give in tropical countries like ours for that?
Salt supplementation.
Salt supplementation, yeah. Next slide,
Anything
please.
else? Anything else you will supplement?
KCl supplementation.
So it is usually hyponatremic, hypokalemic metabolic alkalosis. You also have to supplement potassium during those periods. And does the child have anemia? Does the child have anemia?
Yes, ma'am.
So, sir wants to know what is the peripheral smear and RBC indices.
Peripheral smear showed microcytic hypochromic anemia, ma'am. RBC synthesis, MCV was low and MCV, MCH.
So that should be included in a presentation also. If you see anemia, then the next step will be on looking at your RBC indices to look at what type of anemia. The child can have any type of anemia, even B12 deficiency can coexist. So if there is anemia, then definitely include the RBC indices in your presentation.
Okay.
Okay.
Next slide, please. Next slide. Yeah, I think we have elaborated on this one. Yeah, I agree with the previous slide. I agree with Kalpana, ma'am. Previous slide. Previous slide. Yeah. Therefore, bronchoscopy, the patient is producing copious amount of sputum. Generally, bronchoscopy is not indicated unless there is any focal disease we want to explore. Or if the patient is not producing sputum and you are treating a flare-up and child is not improving, there you need to find out exactly what is happening. Then we usually we do a throat swab, deep throat swab, or a cough swab. Again, if it is not yielding anything, then last resort only we are going to do a bronchoscopy. And we mentioned about fecal elastase, and fecal elastase helps us to classify whether the patient is pancreatic sufficient or insufficient. But the thing is about fecal elastase is, some infants can be pancreatic sufficient to begin with. Therefore, if the patient is pancreatic insufficient, you are going to start treatment. The patient is pancreatic sufficient, that doesn't mean the patient is going to be pancreatic sufficient for throughout the lifespan. Therefore, a pancreatic sufficient patient in infancy can become pancreatic insufficient. Therefore, you need to closely follow this patients. Like probably annually you have to do a pancreatic elastase. Okay, just to make sure the patient is not going in for pancreatic insufficiency. The other thing is, while taking a stool sample, you have to be very careful. When the patient has diarrhea, you can have a false low pancreatic elastase value. Therefore, whenever you take a stool, it has to be formed. Therefore, don't take a stool sample when the patient has got diarrhea. That's very, very important. And HbA1c, as ma'am said, is not a very good indicator for cystic fibrosis, because RBC lifespan, will be shortened. Therefore, HbA1c is not a very good indicator. If at all you have to do a GTT, okay, glucose tolerance test, not HbA1c, for screening for diabetes, cystic fibrosis related diabetes mellitus. Okay, then ultrasound. Next slide, please.
PSSO wants to know what is 3+ fat stools. What is 3+ positive on stools? You're online?
Yes.
So usually we don't grade on stools. We say many fat globules are seen like that. I don't think there is any grading system. I'm not aware. Do they have any grading? I'm really not sure whether there is any grading for stool fat globules.
Very non-specific test, very non-specific test, but we do sometimes, just to patient could not afford. This costs around, fecal elastase costs around 3,500 for the patient. But good thing about fecal elastase is, for small babies who are not able to do a sweat test, and if the patient cannot go to a place where they do the sweat test, you can send the stool sample. Stool samples can be transported. Therefore, it helps with the diagnosis in some patients. Where the patient is in the periphery, if the patient is sick, they can at least send a stool sample to see whether the patient has got pancreatic insufficiency, then diagnose. Next slide, please.
But what will be the ideal method of monitoring your the child is on enzyme replacement therapy, no? So what will be the ideal method of monitoring whether this child has fat malabsorption or not?
Weight gain and frequency of the stools and any abdominal discomfort is there.
If you're giving adequate pancreatic supplementation, how many stools should be there per day?
1 to 2 stools per day.
So there should be 1 to 2 stools per day, and there should not be any abdominal discomfort, and there should be adequate weight gain. So So if you monitoring that in a child, then that is enough to document that the PRT that you're giving is sufficient or not. Okay.
And the radiological signs of bronchiectasis, like it has been given in literature as 3 important signs they have mentioned. One is BA ratio, BA ratio, bronchial artery ratio. The bronchus is usually the size is less than that of the artery, surrounding artery, nearby artery, neighboring artery. But here it's almost equal in bronchiectasis. And if it is very big, you get the signet ring appearance. Okay. And then second thing is non-tapering of the bronchus. In sequential, sequential slices, the bronchus should taper. And here it won't taper. Okay. And that's why we get clamp tracking. Therefore, this is the next sign. And finally, if you see any bronchus 2 centimeter, close to pleural surface, then that again is a sign for bronchiectasis. Not only we can diagnose bronchiectasis, you can also tell what kind of morphological type of bronchiectasis the patient is having, either cylindrical, which one is better, which one is reversible sometimes. I think it's better to have a cylindrical bronchiectasis. Okay, it's better to have a cylindrical bronchiectasis. The chances it might, regress, but if it goes or saccular, I think that's like a burnt out stage. Next slide, please. Next slide.
So is this a HRCT or an ordinary CT?
HRCT was.
It was an HRCT, yeah?
Yes, ma'am.
So what is the difference?
In HRCT, it is in 1 millimeter cut per 15 millimeter, ma'am.
Is that the difference? So when will you prefer HRCT?
To look for the bronchial markings and to trace the bronchus, we have to look for HRCT. 1 millimeter cut will be of.
Or look for, or you prefer it in a diffuse or bilateral disease?
Diffuse and bilateral disease.
So it is preferred in a diffuse and bilateral disease. More than the cuts, in an ordinary CT, what happens is when you get a single cut, usually the images before and after are collimated. Will have an average of all these images in one single cut. So as a result, the finer details or architecture of the lung is not seen. But in a HRCT, what you see is one single cut. So the final details, if you want to detect early bronchiectasis or want to find out features of interstitial lung disorders, then a HRCT would be preferable. But this child has findings of bronchiectasis on your X-ray itself. CT need not be done, and if at all, an ordinary CT even would have picked up this degree of involvement. So saying the left is more involved. They are saying the CT was taken 1 year back, so it's not a current CT. So is bronchiectasis reversible or not?
It is a reversible when it is in a pre-bronchiectasis stage, or in the cylindrical format, it is a reversible thing.
Okay.
Next slide, please. Next slide. Is the circular normal or abnormal? Go back.
It is an intermediate range, sir.
Okay, therefore it's intermediate, like it's not. What is the normal circular rate?
Less than 30 is milliequivalents per liter, sir.
Yeah, less than 30 is normal. And what is abnormal?
More than 60.
More than 60, and usually in duplicate, have to do it in duplicate. Okay. Sarah is asking, are there any false positives? Circular rate.
Malnutrition or when there is a nephrogenic diabetes insipid hypothyroidism, there can be a false positive circular rate.
Next slide. If at all, if you are ordering, if a child has got cystic fibrosis and you want to do a genetic test, how will you order genetic test?
It is mainly done according to the geographic locations and the race and ethnicity.
You know what test you are going to order?
Clinical exams.
Clinical exam. Clinical exam is not specific for cystic fibrosis. If you want to do a specific test for cystic fibrosis, I'll give you 3 options. Okay. Okay. Gene panel. Okay. CFTR sequencing, and then the PCR. Which one you are going to?
Gene panel.
CFTR sequence.
Yeah, I think some labs do only gene panel, and gene panel will not cover all the genes. They will select genes based on the prevalence of CFTR mutations in that region. But India is a very vast country. We don't have data on the CFTR mutations throughout India or in a state like Tamil Nadu. Therefore, if you are going to order like genetic testing, you have to ask for CFTR gene sequencing. They will sequence the entire gene and they find out all pathogenic mutations. Therefore, you have to order for CFTR gene sequencing. That's right. Next slide.
Treatments.
Next. Ma'am.
Yeah, we'll proceed.
Okay.
Treatment, it is a multidisciplinary approach. Since the child's saturation was 90% in the room air, it was supplemented with an oxygen through the high flow nasal cannula, and airway clearance through postal drainage and physiotherapy was initiated. Inhalation was hypertonic saline nebulization. Salbutamol nebulization was also given. IV antibiotics was started according to the culture sensitivity report. It was anti-pseudomonal IV antibiotics for about 2 weeks, 3 to 4 weeks, and along with the child was given a tobramycin nebulization. Child was continued a pancreatic enzyme
That's okay, doctor. You can just proceed.
Yes, sir. The child was again on the pancreatic enzyme replacement therapy with 1,000 international units per kg for the main meal and 500 international units per kg for the snacks taken along with the food. The child was also on the vitamin supplementations of vitamin A of 5,000 international units with vitamin D3 of 800 international units and vitamin E of 100 international units with injection vitamin K 5 mg once a week, sir.
What is the vitamin K that the child was taking?
We've given IV injection only we've given, ma'am.
So you want to give IV for maintenance therapy?
No, ma'am.
No, ma'am. Oral
is
can be
sufficient.
sufficient, ma'am.
So oral, what preparation is? Do you want to give the oral preparation or any other form?
Menadoi in ampoule itself we can break and
So that is more preferable because it is more cheaper than the oral vitamin K supplements. This PRT that you're telling, what is the doses the child was previously receiving?
Since the child was having the same weight from the past 2 years, the child was receiving the same dosage only, ma'am.
So you want to modify anything?
The
child has fat malabsorption in spite of the same dose.
Yes, ma'am.
So how can you improve the fat malabsorption?
by giving PPAs, ma'am.
Giving? Proton pump inhibitors. Yeah, that is one way. That is more indicated in infants where you're breaking open the capsules, usually in a capsule. So you can't make an infant swallow the capsule. So the capsule is usually broken down and then we give the contents along with some jam or just smear it on the child's tongue. In that case, PPAs will be more useful. But even in this child, suppose the child is getting adequate amount of PRT and still is not improving, you can give proton pump inhibitors before the meal. That is one thing. How else you can modify this dose? This 1,000 internationals per kg per meal. How can you want to give us a single dose?
Maximum dose can be increased to 10,000 international units per kg per day.
For one particular meal, the half of the dose can be given just before food, and the remaining half can be given during the meal. Because if you're going to give the entire meal dose before food, sometimes it can just be washed out of the stomach before the food enters the stomach. So you can split the dose of lipase and give. And the second thing, as you said, is adding proton pump inhibitors. Those two can be, and always check what preparation of pancreatic enzyme that they are having. What is preferred?
Crayon is preferred.
Crayon, okay, it is a little costly, but you have to check what brand. Most of them will have a lot of proprietary PETs where, I mean, the amount of lipase is not that adequate. The usual strength that is used is
10,000 international or 25.
So you have to check what preparation they are using, split the dose and add PPAs. The child is going to have malabsorption in spite of your adequate weight. Okay, go on.
That's it. Okay.
Nutritional advice was given to this child. It was high calorie diet of 110 to 200% of normal daily requirement, with high protein, high fat diet with vitamin supplementation and salt of around 2 to 3 millimole per day, with iron, zinc, and calcium supplementation were added. And on the annual follow-up, child was in the anthropometry.
Doctor, stop. Go to the previous slide, doctor. First slide. You said like airway clearance. Can you elaborate on the airway clearance? Because it's a bit too much for your stage, but it's better to know when you go out, you learn things so that it will be helpful when you see patients.
Initially, we'll give a salbutamol bronchodilator nebulization, sir, followed by a hypertonic saline nebulization, preferably 7% saline. Since we don't have that, we use 3% hypertonic saline here. Then after that, the child is posted to a chest physiotherapy. If the child has a middle lobe involvement, the head end is lowered to a 14-inch, in which 3 times per second is done for 3 minutes in each segment. For total duration of around 30 minutes it is done, sir. And if it is a lower lobe involvement or generalized involvement, the head lowering is done for about 18 inches, sir.
Okay. I think you are correct in whatever you have said. But is there any way that you can reduce the timing, like timing of physiotherapy? How many times you are going to give physiotherapy?
For twice a day, sir.
Twice a day. When the child is having a flare-up, probably 3 times a day. And the sequence is very important. As you said, bronchodilator and hypertonic saline followed by chest physiotherapy. And in developed countries, they have other mucolytics as well. Dornes is there that will break down the neutrophils and reduce the viscosity. And what we do generally is nebulization. How long you have to nebulize, salbutamol?
50 to 20 minutes nebulization.
Generally, nebulization is only like 10 minutes. But if you want to reduce the time, you can actually use a spacer and your salbutamol with a spacer. It will take very little time. If you want to give only 2 puffs, probably that will be over in a minute. Okay. Therefore, it's better to give salbutamol with a spacer than hypertonic saline with the nebulization. Now, 7% saline is available in the market. That again, less than 6 years, you go by 3% saline. If it is more than 6 years, you give 7% saline.
So, child is already on partial drainage.
Yeah.
So, a child is already doing this physiotherapy properly, but child is still progressing for bronchiectasis.
Yes.
Do you want to add anything else? Child is an older child, 6-year-old.
We can add an acapella for airway breathing exercise, active breathing exercise, or positive expiratory pressures with high frequency oscillators can be given.
So at least the acapella device, positive expiratory pressure devices can be added in this child. And an older child, like 6-year-old or 7-year-old, can be also taught active breathing exercises. So probably one is the partial drainage. That your technique is good, but you're not sure whether the mother was using the exact amount of foot and elevation. And the surface also should be a little firm to hard in order to dislodge the secretion. So all that minor things, but they have to be told properly for these children who require long-term physiotherapy.
Yeah, therefore, like you not only is a diffuse disease, not only give for postal drainage for that particular lobe which is affected most, and you have to give for all the lobes. And well, after a certain age, children don't want others to tap on their chest, when they become an adolescent or teenager. Therefore, we start a cappella or PEP devices quite early on. Then you have lots of breathing exercises. Therefore, we have to involve physiotherapists, early on. Then we talked about the sequence. The sequence again is very important for, for pancreatic enzyme, food, vitamins. Therefore, if you vitamins, separately, then it's not going to get absorbed. Therefore, pancreatic enzymes, food, vitamins. This sequence is also very important. Okay, and then and again, this child is not gaining weight. This is another issue. How are you going to tackle this issue? Go to the next slide.
We have to increase the calorie density of the food should be increased, sir.
Yeah, like you have got a great plan. Actually, you are going to give 200%. Are you giving? If it's a healthy child is taking 1 plate, this child is going to eat 2 plates of food.
No, only the density can be increased. The quantity will be remaining the same, sir.
Quantity, you are going to make the quantity the same, and you are going to increase the energy density. How are you going to do that? Because this is fat malabsorption. What are you going to do?
There is no dietary fat restriction in the state, because we can give a pancreatic enzyme lipase along with the food. So we can add 2 spoons of ghee to the every food, or oil to the food, sir. And energy dense milk can be added. That is high cereal milk diet can be given for this child, sir.
Yeah, therefore you are going to increase energy density by adding more,
So
more fat. Okay, more fat and more creon. Okay, the family, increasing dose of creon, and our children don't grow that well, actually. Therefore, creon dose is not fixed; it's quite flexible. Whatever you have mentioned is the initial starting doses. Yeah. Then, if the child is not thriving, you have to give more creon, and we have to make sure child is eating good amount of fat. And fat, again, there is healthy fat. Saturated fat is not very healthy, and now people are talking about healthy fat and unhealthy fat. Therefore, it's not about putting in more ghee and saturated fat. You have to put in unsaturated fat as well. Therefore, you have to think about healthy fat as well whenever you give fat. Therefore, you have to give more fat. Okay. Then, as ma'am said, if the child is not gaining weight in spite of eating good amount of food and good amount of creon, then you have to think of other medical diseases which might interfere. What are the things that you are going to look at?
Any endocrine disorders can be there, sir.
As you said, diabetes. If it is an older child, diabetes is one of the important causes. And other conditions can also occur, but it's not very common in our setup. But if you look at Western literature, they will say the child can have celiac disease or dysbiosis, dysbiosis, because this is the motility will be altered, and you can have dysbiosis. These kind of things can cause problems with poor weight gain. You have to think about all these things. But in our setup, it's basically parents, like they have food fads, and they will tell the child has got cold, we won't give this food, that food. They will be very particular with the kind of food they are giving. That's one of the main reasons. And the quantity of food being given to our children are also very less. And most important factor what we see is creon. They won't be able to afford creon. How expensive is one creon? Do you know? Like one creon, 10,000.
One pack of 15 tablets costs 54 rupees or something.
One creon 10,000 will be costing around like 25 to 30 rupees. And some children have to take about 8 to 10 creons. Therefore, it's going to be very expensive. Therefore, they cut down on the creon, then they don't put on weight. And I think what about ICH? Are they giving creon to children with cystic fibrosis free of cost?
Ma'am, they are using creon.
Yeah.
We usually give, sir, but sometimes it goes out of stock.
Yeah.
Sometimes we depend on donors. Sometimes you ask the patient to get them.
Yeah,
So it is really an issue. Other thing is you can ask them, you can group them into, club them into support groups. You
Okay,
can
ma'am.
make them contact support groups. That is one important way where they can have a constant supply of creon in their for these children.
I think you people are very interested in CF and other diseases. Probably your hospitals, will be providing, but like in CMC and all, I have been requesting one person to take.
It is difficult for us also, sir. I mean, for ICH also.
It's difficult, ma'am. That's a main creon is a very important, like component of treatment, but no, people could not afford it. Okay. I think iron, zinc, and calcium supplementation, salt, everything you have mentioned. Okay. Next slide.
What about pulmonary function test? Did you want to do? Child is 6-year-old.
Child was not cooperative at that time. We didn't do any pulmonary function test. We can do.
We should do. We can do. We should do because you have to monitor the decline. It is an important sign of exacerbation also. So even if the child is not very symptomatic and your pulmonary functions are deteriorating, that can again tell you there is something going on. So in an older child, at least more than 5 years, you should attempt a PFT to see what is their baseline level of lung function.
So in annual follow-up, we have to monitor the anthropometry, spirometry with LFT of SGOT, SGPT with serum bilirubin, albumin, and globulin with PT and INR, with calcium phosphate and serum alkaline phosphatase. Serum electrolytes like sodium, potassium, and chloride should be followed with blood urea and serum creatinine, USG abdomen and echocardiogram, and fasting blood sugar with the oral glucose tolerance test, with CBC and IgE and Aspergillus specific IgE, as they are prone for allergic bronchopulmonary aspergillosis, and chest X-ray if indicated. And after sputum surveillance should be done every 12 weeks once. Immunization advice was given to this child, and dietary advice also was given, and child and parents both were given a psychological support.
So what did you survive from the sputum? Surveillance in the sputum?
Because sputum surveillance is done once in 12 weeks, ma'am.
What do you send the sputum for? What do you want to surveil?
For culture sensitivity, many organisms, if suppose the child is having a Pseudomonas aeruginosa, it should be treated. Or if the child is stable with a staph aureus, it can be given an oral medications. Or if the child is having H5 influenza with a well child, we can give an oral medications. If it is really a Pseudomonas or a Burkholder cepacia, we should be treated with IV antibiotics, admitted and treated.
Sputum surveillance is done when the child is not symptomatic. Which comes for routine follow-up, and then you send the sputum. You see whether there is any Pseudomonas colonization and want to eradicate in the earlier stage. It is not meant for when the child is symptomatic. Burkholder cepacia, child will be symptomatic. So that is when that is a sputum culture. So surveillance you do for Pseudomonas aeruginosa and for non-tuberculous mycobacteria yearly once. So both these can be done in sputum surveillance. Sir wants to know what is the immunization advice you gave?
The child should be taken regular annual dose of influenza vaccine should be taken for this child, because it can cause a exacerbation for this child.
So pneumococcal conjugate vaccine.
Pneumococcal conjugate vaccine was given, followed by a polysaccharide vaccine. 8 weeks later, polysaccharide vaccine was also given for this child.
What PCV you gave? PCV 10 or PCV 13?
PCV 13 was given for this child.
Can you give PCV 10?
It doesn't cover the other 3 serotypes, which is more prone to get necrotizing pneumonia.
So it is not approved after 5 years of age. By theory, we are not supposed to give PCV 10 after 5 years. So PCV 13 followed 8 weeks later by you have given the polysaccharide vaccine also.
Yes, ma'am.
Okay.
But doctor, like this is like more of my advice. What works in CF? Like it's basically education. Like we have to spend lots of time with the parents educating about the disease. Second thing is empowering them with the skills needed to manage CF, because like it's not our prescription which is going to work. It's basically their physiotherapy and the food they are going to give. Therefore, we have to empower them with the skills necessary for airway clearance and a good diet. Okay, and third thing is like motivating them. Lots of parents will be depressed, and they know this child is not going to recover. I think it's very, very important to motivate that, there will be some light at the end of the tunnel, so that they have to keep going. Therefore, what we see in lots of patients is they usually give up, and they don't come for regular follow-up, and they don't give the medicines properly, and then they land up when the child has got, like what you said, respiratory distress and oxygen requirement. Therefore, these three components are very important. Like as you said, multidisciplinary management, educating, empowering, and motivating them. The last thing you put, the last point, psychosocial support. That's very, very important. Ma'am.
Did you do the Wrangling test? Yes, sir wants to know.
So, ma'am,
Wrangling test.
since it was diagnosed, we didn't do here. ma'am.
So, do you want to tell something? When will you take it as a positive test?
After 3
3
minutes. If
After 3 minutes or
before 3 minutes.
before 3 minutes? So, if a wrinkling appears before 3 minutes, what water will you use? Hot water, tap water, cold water?
Tap water.
A normal temperature water, and the wrinkling appears before 3 minutes, then it is a good screening test for cystic fibrosis, especially in younger children. Okay. Ma'am, anything else?
Ma'am, Kalpana ma'am, like I want to highlight one more point as well. And in suspected children with chronic wet cough, okay, when do you do it's not necessary for a child to have clubbing to do a CT scan. Clubbing has appeared, it's a very, very late sign, and we are seeing lots of PCD patients who don't have clubbing but will have bronchiectasis. Therefore, all bronchiectasis patients won't have clubbing. Only 60% of bronchiectasis patients will have clubbing. Therefore, if you come across some patient with a chronic wet cough, I think if the patient doesn't have clubbing, that doesn't mean the patient doesn't have bronchiectasis. Therefore, if the patient has got wet cough for more than 4 weeks, what we say that condition, 4 weeks, if there is no specific underlying cause, and you give antibiotics, and if the patient responds to antibiotics, what do we call that condition called?
Protracted bacterial bronchitis.
Okay. If you diagnose a child with protracted bacterial bronchitis, you give antibiotics, they usually respond in 2 to 4 weeks. And what antibiotic you are going to give generally? Like what is the drug?
Amoxicillin.
Doesn't work against non-typable H influenza as well as like H influenza as well as M. catarrhalis. Therefore, amoxiclav will be a better antibiotic. Okay, amoxiclav will be a better antibiotic. We give, and the child responds, that's well and good. It's just protracted bacterial bronchitis. If there is no response to your antibiotics, you have to suspect bronchiectasis. That's one. Therefore, you have to do a CT scan at that stage. You don't want to have a burnt out disease. You have to diagnose early. And if the patient responds, but it's having recurrent bacterial bronchitis, then again you have to do a CT scan. Therefore, don't wait too long. The patient has got wet cough for more than 4 weeks. Think about bronchiectasis, treat with antibiotics. If there is no response or there is recurrence, do a CT scan. Okay. Therefore, X-rays, it's not a very sensitive test for bronchiectasis. Therefore, as you mentioned, CT scan is the CT scan is very sensitive test for bronchiectasis. That's another point I want to tell you. Yeah.
Can you please suspect pertussis because you're dealing with chronic coughs? What should be the duration of cough?
6 months.
When you suspect pertussis?
Chronic cough with post-acute vomiting is present, ma'am. Or in infancy, if the child is going in for apnea, you have to suspect pertussis, ma'am.
What is the duration of cough, and will all children with pertussis have whoop?
No.
No, they will not have whoop. So what duration of cough will you suspect?
6 weeks
100 days cough.
6 is too long, man. So any cough lasting more than 2 weeks, I can think of pertussis also. But will have some characteristics other than whoop. Whoop is not present in a child who is either partially or fully immunized. Can you have pertussis in a child who is fully immunized? Who has received DPT fully immunized?
Yes.
So what is the efficacy of pertussis vaccine? What is the efficacy of tetanus in a DPT vaccine?
100%.
100%, very good. For diphtheria? Again, it is good. It is 97%. For pertussis, it's only 85%. So even if the child is fully vaccinated or completed his schedule, the child can have a breakdown of pertussis. So any cough more than 2 weeks, think of a pertussis, especially if the cough is paroxysmal or has a whoop or has post-tussive vomiting. Children who are immunized will not have this whoop, but they can have this post-tussive vomiting and paroxysms. Any one of them are present, think about pertussis also. So any child with chronic cough, not actually chronic cough, any cough more than 2 weeks, think about pertussis in addition to what you usually think of like tuberculosis and the others. What is the triad of presentation makes you suspect cystic fibrosis? This is Dr. Janani Madam's query.
Failure to thrive when the stool increased stool and stool frequency and volume of the stool with oily in nature, with chronic cough, chronic wet cough. No?
So one is the respiratory system, second is the malabsorption. What is the third triad? Electrolyte abnormalities. Electrolyte abnormalities again will give you a clue to suspect cystic fibrosis. At what age will you get Pseudo-Bartter syndrome? What is the age group you get Pseudo-Bartter? What is the presentation in infancy? What is the presentation in the newborn period? What will be the presentation in older children?
In newborn meconium prolonged jaundice might be a presentation.
Okay.
Diagnosed respiratory distress.
Respiratory distress will not occur in the newborn period. In the newborn, they'll be presenting as meconium, intestinal atresia, prolonged jaundice, all that will be present. So when will you get in infancy?
Infancy, recurrent bronchiolitis.
So recurrent respiratory tract infections. They'll start developing RRTs during infancy, then
dehydration with Pseudo-Bartter.
Dehydration with, you have mentioned about dehydration, but the catch there is dehydration on minimal loss. That is with 1 or 2 episodes of loose stools or 1 episode or 1 or 2 episodes of vomiting, child will become severely dehydrated, lethargic, and will require admission in the hospital. That will be the clue in CF dehydration. Okay, so failure to thrive will start during infancy. You will start having a recurrent respiratory tract infections, and then you will have your Pseudo-Bartter syndrome. All that will start during infancy. In older children,
Chronic rhinosinusitis.
okay, sinusitis, then nasal polyps, very good. And they'll develop bronchitis. In younger infants, they'll be presenting with more of vitamin deficiencies like rectal prolapse because of protein malabsorption, edema because of hypoalbuminemia, some acrodermatitis enteropathica or petechiae or fibrosis. All this will be present during infancy. Older children will be presenting with more of respiratory tract infections, features of bronchitis and more of sinusitis, polyps, then your diabetes mellitus, your CF-related lung disorders and all that will be a presentation during the older children. Okay. How do you differentiate Pseudo-Bartter from Bartter? Suppose you're seeing a young infant with dehydration and you take an electrolyte, you see metabolic alkalosis. So what differentiates from Bartter?
No hypocalcemia.
No polyuria.
History-wise, no polyuria.
Okay, that is not there. Any objective way you want a history or you want to document something? Like what's different? Why it is called Pseudo-Bartter and not Bartter? It is differentiation is in the urine chloride. The urine chloride will be normal in CF. Okay, and it will increase in cystic fibrosis. That's how you differentiate pseudobarter as well as the Bartter syndrome. So anything else, sir?
I think time is up.
We have 4 minutes
Only
more.
3 more minutes, I think.
Yes.
I think they did very well. Such a extensive questioning by all the eminent faculties, and she has boldly answered. I'm sure other judges may agree with me. So congratulations to the team. Thank you.
Sir, Ramachandran sir.
Thank you, sir. So it was a very good.
சார் நீங்க கூப்பிடாமலே சொல்லிட்டேன், மன்னிச்சிடுங்க.
சார்
Sir,
தலைவா நீங்க என்ன
நீங்க சொன்னா
வேணா
சரிதான்
பண்ணலாம்.
sir.
உங்க ஃபீல்டு நீங்க ஓப்பனிங் பேட்ஸ்மேன் இறங்கலாம், நீங்க பவுலிங் பண்ணலாம், என்ன வேணா பண்ணிக்கலாம்.
சார் நீங்க ஒருத்தர் சொன்னா 100 பேர் சொன்னாங்க.
ஆமா.
Absolutely agree with sir. Whatever very nicely discuss also the moderators. So it's and the students did very well. See, they have got so much of practical knowledge also, not only a theoretical background. I think it also tells about the good training they have had and also their own initiative. So I just want one thing to be asked. Sometimes these patients like this, they are there in the hospital for 1 week, 10 days. The students present only on at the time of presentation, what is the clinical picture? You have to tell the clinical course in the hospital on the day of your examination, how the patient is. That will tell some of the findings which you can explain when the child is very comfortable. But you would have, you might be presenting the features when the child came, when the child was more dyspneic, more tachypneic. So include the course in the hospital also in your clinical presentation. That will complete the picture as on date. Otherwise, it's an excellent presentation. Thank you so much.
Thank you, sir.
Dr.
I
Rama
want to
madam.
make one more comment, sir, which I heard recently from Balaji. Okay, it's similar case presentation. So he was mentioning specifically about aquagenic wrinkling, and it seems the wife was, she went and tested her husband, and it was positive, and then she was clever enough to do it herself, and then she came and told that he is probably a carrier, and of course he was positive. And this is for your information, because it was told in the similar platform where he was discussing the case, the undergraduate bronchitis. So I thought I would remind these postgraduates also about it. Thank you. You understood what I said?
Yes, sir.
And also counseling is also very important, how to counsel the parents and how to mention how to look up for other members in the family with similar symptoms and the future this thing. Thank you so much. Thank you, Rajan, for having me again.
Sir, one more thing, sir. Dr. Rama madam, yeah.
Yeah, I just want to congratulate the moderators. Excellent discussion, and as always, although however senior we are, I think we get to learn a lot during these PG clinics. Not only meant for PGs, meant for us also. I think to carry home a lot of information. Kalpana and Anthony did an excellent job. Of course, the PGs also. I think there were very few questions which were unanswered, so they're very well prepared. And congratulations to all of you, and Rajendran and team also.
Thank you. Dr. Janani madam.
Yeah, I think same as Rama said. Excellent presentation and excellent discussion. Thank you.
Yeah, Dr. Ramesh sir. Yeah.
Another enjoyable teaching session, sir. The students presented well, but only thing is, it's unfortunate that the other learners were not talking too much. In spite of you repeatedly asking them to talk, ask questions, they are not participating. I think, as you suggested, they should have separate tab or to discuss, so that you can ask directly questions to them. And regarding the presentation, this is a teaching session, so they had access to the investigations. So they were able to narrow down the diagnosis. But in the university examination, you have no access for the investigation. So the differential diagnosis should be little more elaborate. And the moderators did an excellent job of, they not only asked questions, they also teaching them and practical aspects, and that's very nice. And as Dr.
They have to teach. Otherwise, how can a postgraduate know so much about a particular disease, which is dealt only by specialists? So I think it is a learning experience for everybody. Yeah.
Dr. Anthony also said there are too many negative. I also agree with him, because it is like a cinema shooting presentation, cinema, like editing. They play thousands of shots, then they edit into a nice story. Like that, a presentation also, you should ask in detail all questions, but edit nicely so that your questions, your findings or questions should be either to aid to arrive at a diagnosis or rule out some diagnosis. And again, a differential diagnosis should be discussed in greater detail. But of course, this is a teaching session and we learn more about cystic fibrosis. Congratulations to the whole team. Thank you, Dr. Rajendran, for the opportunity.
Thank you, sir. Dr. Elilasi, madam. Yeah.
So as usual, another very good brainstorming learning session. The message actually, this is diagnosis already made, yes. But then we thought, because nowadays we also accept that cystic fibrosis is not an uncommon disease. We are seeing more, and we know that what is important, just not drugs or anything, the physiotherapy, the nutrition and everything. So I think both the moderators did an excellent job, and of course the PGs. And so, I mean, we keep learning as and when we grow. What are the things to do, what not to do, how, and as Sir said, we have to screen the parents because it's a non-consanguineous marriage, first child, and neonatal screening for IRT. All this is brought out. So Kalpana and Anthony, they really did a justice to this. And really the PGs, congratulations and all the best. Thank you, sir. Thank you for the opportunity.
What are the names of the PGs?
Vidhu Varsha, Mari,
Venkatesh. But very important, at least you can answer in if they sit separately, they can at least answer in the chat box.
Yes, sir.
Not directly be asked, but you can put your answer or you may be asked directly.
So maybe hereafter questions we address the presenter.
One sitting in the middle, presenter is Vidhu. Who is sitting in the middle?
Middle is Mari, this time Vidhu, and that is big.
Okay, right. Okay, thank you. Thank you, sir.
Yeah.
I think they can come with the prepared questions also, the other learners, because you are dealing with experts. They will be able to clear their doubts and clarify many things that they may not know, even their own teachers may not know.
Yeah, I myself had a question. Kalpana, how do we get clubbing history? You said you asked whether the mother should have...
Usually, whether it's grade 3 or grade 4, we ask for bulbous swelling of the fingers.
Anything abnormally seen in the fingers recently, that's how we can put the question. Have you noticed anything unusual about the nail bed of a child? Or...
Yeah.
Thank you.
Okay.
Thank you, ma'am.
And I thank really Dr. Anthony, in spite of his fever, I think he's sitting past 2 hours and really appreciate his willpower and as well as commitment. Thank you, Dr. Anthony.
Okay.
Yeah. Yeah.
Get well soon.
Thank you, sir.
Soon.
Yeah. Dr. Kalpana, I thank Dr. Kalpana. I think she has interacted with
Very nice to see all the teachers. Thank you. Thank you.
Thank you. And Dr. Yeah, PGC, your feedback, please.
What can they say? You can't ask them.
No. That's how they feel.
They
and,
enjoyed. From their face, we can see they enjoyed the whole session.
They're relieved, I think.
Sir, how many PGs are participating, sir? I could see only 12 participants. Is it only the panelists?
Only panelist link will be there, sir. So you can. It's an all-day level postgraduate teaching program. Usually it will be around.
It will be known only to the DAP. The exact number that will be known only.
Only the DAP only knows, sir.
Yeah.
Okay. Because it should attract more PGs, because there are more than 30 medical colleges in our own state.
We are getting it is all-day level telecast, sir. So usually we'll get 650 to 700 now, sir.
Oh, that's very nice, because it benefit a lot of students.
Sometimes it may go up to 900 also, but it's available actually in IAP TNC YouTube channel, sir. So IAP TNC YouTube channel, it's available this recording, and anytime they can go and see.
But nothing like live interaction like this.
Yes, sir.
Yeah, seeing all the brilliant faces, you get to know more.
Yeah, Vidhuvasha, I think you want to ask how is it? What's your yeah?
It was a nice training for us, sir, to be before the exam, to how to present and what not to ask, and what specifically we have to ask, and it was nice. Thank you so much, sir, for this presentation, and it was a useful as well in a practical aspect also. So we come to see more cases this way, and for this nebulization and all. After reading this and presenting, we could be applying it on the patient. It will be more useful for them and also for us.
Vidhu, you said no bilateral pitting pedal edema. If there is no edema, simply say no edema. Then there is a possibility of a unilateral non-pitting edema. So there should be no ambiguity.
Okay.
And it has to be crisp and clear.
Terence face I am not able to see. All the
you should allow the examiners to ask some questions. So don't reveal everything. So you should tempt them to ask questions and you can answer some of them.
Anthony, Terence should come to the light, you know. Face is looking, we cannot see your emotions after the presentation and answer session. Because
director Mari emotion
Ama, face is index of the mind. பெரியவங்கலாம் சொல்லிருக்காங்க. நீங்க சந்தோஷப்படுறீங்களான்னு தெரியலையே. நாங்கெல்லாம் எங்க முகம்லாம் தெரியுது இல்ல.
So unmute, Anthony, unmute.
கண்டுபிடிக்கிற மாதிரி உங்க ஃபேஸ்ல இருக்கிற விங்க்லிங்க பார்த்து தெரியும்ல.
இல்ல sir, it's good to see all the teachers. That brings lots of good emotions and old memories as well.
Yeah.
On behalf of IAP TNSC, I thank the chairperson, Dr. Elilasi Madam, and moderators, Dr. Kalpana, Dr. Anthony. I thank all the judges, Dr. P. Ramachandran sir, and Dr. Ramesh sir, and Dr. Rama Chandramohan Madam, and Dr. Janani Madam, and Dr. Srinivasan sir. I thank all the students from ICH. Thank you, Ananda. Thank you.
Thank you, sir. Good night. Goodbye.
Thank you.
Thank you, Shivagi.
Thank you so much.